Thank you. Thank you. Thank you. So you can confirm I'm audible. I confirm all the panelists have arrived. Dr. Zipora Ali, I can see you. Dr. Asaf Kigenjui, I can see you. Dr. Esther Nafula. And, oh my, Maculin, have you joined? Okay, I believe Maculin is also in the call. So thank you everyone for joining. My name is Dr. Jeffrida Chepchumba. I work with the Ministry of Health under the National Cancer Control Program. And this webinar is being organized by the program as part of the dissemination of the Kenya Palliative Care Policy 2021 to 2030. This policy was a collaborative action of various stakeholders in the Ministry of Health and also our partners. And we finally launched it in October, and now we'd like to disseminate it to various places in the country. And this is actually our first dissemination webinar, and we are really glad that you are part of this team. We thank you for coming and for joining. So we're going to have 4 panelists, all very well conversant with the palliative care issue in the country. They were all very instrumental in this policy development. So we can be sure that they're going to actually disseminate this policy in the best way possible. So in case of any questions, just put them in the chat, then we shall address all your questions. So thank you so much. Dr. Zipora Ali, you can begin the introduction. Thank you.
Sorry. Good afternoon. Can you hear me?
Yes, we can hear you.
Okay. Yeah. So good afternoon, everyone. Thank you very much for joining us for the dissemination of the palliative care policy. As Dr. Joyfrida has said, this is a recent development in Kenya. After so many years of trying to get this on board, finally it's there, and we are really looking forward to this policy, probably helping bring a big change in how patients in our country access palliative care. So I'll be doing the first part of the dissemination, and then other colleagues will come in to do the other different chapters. The policy is actually for 2021 to 2030, and as we'll see later on, the vision is towards achieving the highest standards of palliative care, not the vision, but the slogan. So my name is Dr. Zipora Ali. I am the current chair of the NCD Alliance of Kenya. I'm a palliative care physician. I was instrumental in starting the National Hospice and Palliative Care Association in 2007 and retired recently from the association, but I also worked with the Nairobi Hospice for over 15 years as a senior medical officer. So I'm really happy to be here, to be given the chance to be able to communicate about this policy to the rest of colleagues working all over this country who need to understand how this policy is going to be and how we can help implement this policy, because it's about all of us being part of this policy. It's not just the implementation from the government perspective, but even ourselves as healthcare providers. How do we ensure that this policy is implemented? How to ensure that actually people who need palliative care access it from wherever part of the country, at whatever level of care they are in, including their home, that they have access to good quality palliative care and pain relief. So before we start, sometimes you can be disseminating something and people don't understand what it is. And I always think it's good to remind us of what palliative care is. And if you look at the slides, the definition for palliative care from WHO, and I see some colleagues who are involved in this definition. I can see Dr. Anne Merriman, myself, who are actually involved in shaping up this definition in a meeting in South Africa in Cape Town in 2002. It focuses on improving the quality of life of patients, whether they're adults or children. It cuts across all the ages, and not just the patients, but also their families. A lot of times as healthcare providers, we deal with the patient, and not even the patient holistically. We deal with the disease mostly and forget that this disease is actually affecting a person with feelings, with everything that a person has in their life, and deal with the disease and forget that this disease is not just about a person, but also it's about their families as well. And these are people usually are facing life-threatening illnesses. Sometimes we say life-limiting illnesses. And these days we tend to use the terminology serious health-related illnesses. It's about every illness that is serious that affects a person's day-to-day quality of life. And so the focus is on preventing and relieving suffering by identifying all the problems that the patient might be having early enough, correcting them, doing a thorough assessment of their different physical, emotional, psychosocial needs, and then treating these things as much as we can. Really, so it's about physical, psychosocial, spiritual, the elements of care. But sometimes we also add financial, because most of our patients are totally broke by the time they come to palliative care. They have spent all the money, they have no money left, and they're also financially crippled. So again, financial aspect of it, I like to add to the context of financial aspect, because we see a lot of problems with patients who come to palliative care, they have no money left. So in the yellow part of the slide, it talks about the different things that we need to look at about affirming life and seeing death as a normal process. It talks about quality of life. It talks about, we don't practice euthanasia. People think if you go to a hospice, they're going to help you die faster. We don't do that. We focus on quality of life. And even if possible, on even improving survival, lengthening survival where it's possible. And of course, we focus, like I said earlier on patient and family, because family is very important. They're the ones who take care of this patient and they're meaningful to this patient. And of course, palliative care cannot be given by one person, because you're looking at the physical, emotional, psychosocial, spiritual, financial elements of care. We need many different types of people to come and help us to be able to support one patient. So it's not just one man show. You have to work as a team in terms of supporting patients with needs for palliative care. And of course, like I said earlier on, we are focusing on quality of life, but also remember palliative care is not an end of life care only. End of life care is part of palliative care. Palliative care starts from the time you make a diagnosis, you start bringing in the palliative care team to support this patient throughout the journey of their illness. So it's really important that we bring in the team early enough so that the patient can have good quality of life. So it's not just about end of life care. If you're treating patients for cancer, and you're aiming at cure, the palliative care team is also very important in the treatment of this patient as they go through their illness. So you could actually be providing palliative care at the same time that you're giving chemotherapy, radiotherapy, or surgery, or whatever treatment you're giving to whatever illness it is. And remember, palliative care is not only for oncology cases, it cuts across any life-threatening illness. Other NCDs, infectious diseases, all these people will benefit from palliative care. The elderly, people with congenital diseases, will actually, children with congenital diseases also benefit from palliative care. It's not only for adults, only it's also for children. When you talk about palliative care children, we focus on the whole aspect of care, body, mind, and soul. And we also focus on the patients, on the family of the child. And it can be given at every level of care for children and for others as well. So remember, there's also pediatric palliative care, not just adult, but pediatric palliative care is also very important. So like I said earlier on, it starts from the time you make a diagnosis. And one of the things we want to focus on, especially in this policy, is that it should be a continuum of care and should be given at every level of health service. It should be given at the tertiary level, right up to the community level of the patient's home. So it can be given at every level of care to enhance quality of life of the patient. And then, like I said earlier on, one of the things we do is also part of palliative care is end of life care. And again, I want to emphasize palliative care is not equal to end of life care. End of life care is just a component of palliative care. So again, when a patient, if we realize a patient is not going to get well, they're probably approaching end of life, we need to focus on supporting this patient to live well the last few days of their lives, weeks, months, and to die well, so that they have what you call a good death. Death is never good, but we have a way to explain that a good death in palliative care. We'll be able to meet the goals of this patient, have talked to them. They've probably done things like writing their wills, talking to their families, focusing on things that they have not focused, they wanted to focus on and had not focused on. So finishing the business they needed to finish. So again, it's really important that even as a patient is dying, we support them. The founder of palliative care, Deb Cicely Saunders, says, you matter because you matter up to the end of your life. And we will do everything that we can to support you live actively as much as you can. So even the last breath, when the patient is taking the last breath, they matter to us. So we have to make sure that they're comfortable, have dignity, they're dying also well. Once the patient dies, it doesn't stop there. As clinicians, we need to be able to support the family of this patient in bereavement. Bereavement starts when already you're told that your father or mother or your child or your spouse is sick and has a terminal illness or a life-threatening illness, you already start grieving at that point of time. So again, the focus on bereavement and grief might be just be a continuous, a continuous support throughout the patient's illness, and also when the patient dies, we intensify bereavement services so that we can identify, bereavement, abnormal bereavement, but support the patient throughout, the family throughout the process, so that at least we help them come to healing. So we are focusing on improving symptoms, dignity, quality of life, and supporting the patient and the family. So again, when we're developing this policy, we looked at the status of palliative care globally. There are quite a number of reports, and these are available on the website. You'll find them. There's the 3-country report for children's needs for palliative care. One of the countries that was involved in this report was Kenya, and we're not doing very well at all in pediatric palliative care. Less than 1% of children who need pediatric palliative care in this country have access to it. So we need to ensure that this policy will help us improve from the 1% to reach at least 50 to 60% of the patients, children who need palliative care, if not 100%. And again, these documents look at the need for palliative care in different parts of the world. We are told that where there's more need in developing countries, for example, Africa, where there's 80% need for palliative care, is where we have the least palliative care. 20% of palliative care is actually in low and middle income countries where we need it most. And the rest of it is in either America, Australia, Europe, where they probably might need it less than we do. So again, we need to be able to balance some of these issues, that we have access to palliative care for all those who need it all over the world. We don't have the accurate statistics for Kenya in terms of people who need palliative care. I know our policy says we are only reaching 1%, but I believe we are reaching more than 1%. We need to also look at how can we, improve our data collection. How can we put evidence out there to show how many people in Kenya need palliative care. But just think about the number of new cancer cases that we have every year. We are told about 30,000 patients develop cancer in this country every year. So that 30,000 patients, those 30,000 patients, are they receiving palliative care? We are told 50% of patients in hospitals have got NCDs. Are they receiving palliative care? We know about 6.4% of our population live with HIV/AIDS. If they are very sick, do they receive palliative care? So we need to ask ourselves these questions, and maybe probably through the Ministry of Health and collaboration with the relevant stakeholders, look at, come up with actual figures that can help us even implement this strategy. How many people need palliative care in this country, whether they're adults or children or elderly people? So you can read these reports on the different, on the website. You can find them on the website and read about them. We'll actually realize there's a lot we need to do as Kenya to be able to improve access to palliative care in our country. So WHO came up with this figure in terms of how do we, with this approach on palliative care, how do we ensure that palliative care is fully integrated into our healthcare system. So this is the model that WHO has been pushing for many years. It talks about education. Education is not just healthcare providers, but even media, public, policy makers, and all those things. It talks about drug availability. Do we have the necessary drugs? And for palliative care, we usually try to say that opioids are the mainstay of palliative care, because if you can't manage moderate to severe pain, then you can't say you're providing palliative care. But there's more than pain management in palliative care, of course. Do we have the drugs available? Do we have the policies available? Are we implementing what you're doing? So for us in Kenya, we actually started bottom up kind of. We started with ensuring there was education. We're trying to have education across the country for healthcare workers, community health volunteers. And then we also focused on advocacy for drug availability. Now we have our drugs like morphine and the rest on the essential medicine list. We started working with the government to ensure palliative care is integrated into the public healthcare system. We work with private hospitals and the rest. So we started from bottom up, and finally we've come up with a policy. And this is because that is the way it could only work for us. And now we have a policy. So we hope that we can actually strengthen all these other elements to ensure that palliative care is accessible to everybody who needs it. So again, some things that have helped with this policy. As we're doing this policy, we reviewed quite a number of documents in the country. One of the things that we reviewed was the resolution for palliative care that was passed in 2014. And I've put a picture of it there. This resolution was very important because it was the first resolution ever on palliative care. It talks about strengthening of palliative care as a component of integrated treatment within the continuum of care. It focuses on education, policies, drug availability, supporting carers, and also on quality and strengthening networks as well. So you can read this again on the WHO website, it's available. But again, I want to also emphasize that Kenya was very, very instrumental in this policy. In fact, Kenya was one of the countries, was the main host country in 2012 when we had a side event at the WHO offices in Geneva to have the first ever side event on palliative care at the World Health Assembly. And Dr. Kimani, who was the then Director of Medical Services, was a keynote speaker. And so we were part of this policy, and that's why we should ensure that this policy, this resolution is also enacted and implemented in our country. So again, we were really part of this resolution that talks about integration of palliative care. But in Kenya, we also have the global, but in Kenya also, we also are a member of the Global Action Plan for Prevention, Control of NCDs. And so we need also to be ensured, which actually talks about from prevention to palliation to rehabilitation, we need to ensure that we're also doing what we had signed. And then also the Sustainable Development Goal, healthy lives and well-being, talks about palliative care. And then in Kenya, just locally, we have the Health Act, which talks about palliative care, Vision 2030, the Kenya Health Policy, the Cancer Control Strategy, the Cancer Policy, and also the Universal Health Cover, but also the National Cancer Control, the National Cancer Control Program, and also the NCD strategy that was launched recently talks about palliative care. So we have palliative care captured in many of these things, and we need to ensure that it's very well implemented in our country. So we did a situational analysis because you can't really write a policy unless you understand some of the things, the gaps that are there. And we find quite a number of gaps that are existing. We did a survey, a team from the National Cancer Control Program went out into the field to gather some information. And some of the things that we found were that palliative care is not adequately provided across the healthcare levels. And then there was lack of healthcare workers providing palliative care. They were not enough. There were not many of them trained. And those who were trained sometimes were sent in a different place, so they were not able to practice what they had been trained. We had inadequate access to palliative care services, inadequate care for caregivers of persons living with palliative care needs. So again, caregivers, were not well, equipped to take care of their patients at home. And then also we had things like lack of awareness in the community on the importance and need of palliative care. Most people don't understand what palliative care was. Most people those who have heard about it thought it was end of life care and did not want to send their patients there because they thought you're giving up on your patient. There was lack of dissemination of palliative care policies and guidelines to policymakers. They did not understand what it was. And there was also inadequate capacity for healthcare workers to adequately provide palliative care services. I think that's repeated. And the lack of recognition of palliative care and career progression by some professional regulatory bodies. Again, that has come up several times. When last week in one of the webinars we had, people are not recognized, especially nurses, when they specialize in palliative care. And inadequate palliative care student placement while in training. So some of these are the gaps that we came across, and we have tried to address some, how we can also, we have tried to look at how we can address these challenges in the policy. So this is just to show you what has been going on all this time before the policy was launched. There has a lot that has been going on, especially through the partnership of Kenya Hospices and Palliative Care Association and the Ministry of Health. We have a training curriculum for palliative care that needs to be reviewed. It's over 10 years old. We have the palliative care included in the Kenya National Patients' Rights Charter as a right. We have palliative care guidelines that were also developed, and need to be reviewed now, the 2013. We have palliative care included in the Bachelors of Medicine and Bachelor of Surgery core curriculum, but it's not really being taught very well. It's in the curriculum, but we need to improve the teaching part of it. We have a handbook on legal aspects of palliative care, and also palliative care has been put into the nursing curriculum for nurses, whether it's at the diploma level or the BSN level, and then many other things. We actually work with KMTC to start a palliative care training for nurses in KMTC that has been going on since 2013, and I think has graduated quite a number of students. And then recently, of course, we had the National Strategic Plan for Prevention and Control of Non-Communicable Diseases. This is the second strategy in this country and also has captured palliative care, the training, the guidelines for treating cancer, and of course, the essential medicine list has also included essential medicines for palliative care, especially the opioids. So there is a lot that has been going on, a lot of developments, and all these have actually had to accumulate to be able to bring about a policy. So those are some of the things that have been going on. So as I conclude, this policy has got very, very important things that we need to focus on and remember. One of them is the vision. Vision is what we all share. What we all share here is a vision that a Kenyan population with access to quality palliative care services. We want everybody in this country who needs palliative care services to be able to access them, irrespective of who they are, age, gender, sex, religion, color, where they're coming, socioeconomic status, they should be able to access palliative care services equally, and not just any palliative care services, but quality palliative care services. Of course, the mission for this policy, and I keep on saying we, because this policy belongs to all of us here on this webinar. It belongs to all of us as healthcare workers, as people who care about our patients. And so the mission is to ensure provision of timely, culturally appropriate, evidence-based, holistic palliative care services for the improvement of quality of life for persons living with palliative care needs. So I think this, for me, brings up the big challenge of, are we doing enough research to have our own local evidence in terms of palliative care? And we should be challenged as healthcare providers. Do we have any local evidence that we can use to ensure that we are giving the best quality services for our patients? So the goal, of course, is to enhance palliative care services in Kenya by guaranteeing equitable access to quality services at every point of demand. And this brings in the issue of UHC. Are we ensuring that palliative care is captured in a UHC package? Are we ensuring that it's part of the NHIF package? So again, like Dr. Frida mentioned earlier on, we launched this palliative care policy early October, 8th October, during the World Hospice and Palliative Care Week in Kenya, just before the World Hospice and Palliative Care Day. So this is a very important document for those working in healthcare services. You don't have to have been trained in palliative care to realize this document is important. As long as you're a healthcare provider, you should understand this actually applies to you as well in terms of what services you're going to be giving to your patient. So it was, of course, launched by the First Lady of our country, Mrs. Honorable Her Excellency Margaret Kenyatta. That is just a picture that was there. And we have all this, the policy, palliative care policy brief that actually I hope that Maculine or one of the people at the session will be able to share a link to some of these documents on the chat so that you can access these documents where you are. So yes, that was my part. I just wanted to share that we have a policy, and the others will be talking about the pillars of the policy and the implementation plan. But we are hoping that this policy is not just a policy for a few people here, but it's a policy for all of us working in the healthcare sector. And it's the one that we are going to ensure that our government puts systems in place to enhance palliative care and to make sure that everybody who needs palliative care has access to good quality palliative care from every age, from every, from the prenatal palliative care to the time of bereavement for patients and family if the patient is going to die. But of course, as much as possible, we should aim at cure for our patients, and where we are not able to cure, comfort and provide comfort throughout the continuum of care. So thank you very much. I'm handing over to the next speaker. Let me stop my, Thank you. I think the next speaker is Dr. Asaf, or I'm not sure.
Thank you very much. The next speaker. My name is Makila Natieno. I'm the Executive Director of Kenya Hospices and Palliative Care Association. And I'm going to continue from Dr. Zipi, who has introduced palliative care and the reason for palliative care and the policy. So the policy is anchored in 7 pillars, which include advocacy and communication, leadership and governance, service delivery, human availability and access to essential medicines, human resource and education, health information systems and research, and healthcare financing. At Advocacy and Communication, we aim to promote access to information and awareness on palliative care among all stakeholders. As you've seen from the previous presenter, there's a lot of information gaps on palliative care. People think palliative care is about dying, and many other myths about palliative care. So this should help in supporting and the information on palliative care. The next one on leadership and governance, we are looking at ensuring strategic governance frameworks exist with proper coordination, oversight, and accountability. So for palliative care to develop as a discipline, we need to have the policy frameworks in place. And we are happy that the palliative care policy is one of them. There are many others, like the strategy, the guidelines, which we are to work on, but we are happy that we are starting. Then under service delivery, we want to ensure that there's access to holistic and culturally appropriate palliative care services at all levels of the healthcare systems. And I want to stress on culturally appropriate palliative care services to ensure that the palliative care service that we promote is the one that is acceptable and applicable to our Kenyan society and our Kenyan context, and not only carrying information and models from other places and bringing without adapting it. Then on availability and access to essential medicines and commodities, we seek to ensure access and affordability of palliative care medicines and commodities at all levels. We all know about the use of morphine, which is a standard for moderate to severe pain, and other commodities as simple as even like even gloves, like even many commodities that people with palliative care need use. Some of them are not available, are not accessible, are not affordable. So we seek to support that. And then under human resource and education, we ensure an adequate, knowledgeable, skilled, and motivated health workforce for provision of palliative care services. I assume most of us who are attending this session are healthcare workers, but we are much more, the health workforce is much more than the trained healthcare workers. We look at community volunteers, we look at caregivers, and all the other people, stakeholders who are not necessarily healthcare workers, the legal fraternity, the media, who are linked in one way or another to palliative care. And then under health information systems and research, we provide timely, reliable, and accessible quality health services information for evidence-based decision-making and research to generate innovative solutions. We know that palliative care, just like any other discipline to develop, we need to have evidence-based practices which are informed by research, by audits, and by manipulation of data that is collected in a quality and assurable manner. Then under healthcare financing, mobilize adequate financial resources to facilitate successful implementation, monitoring, and evaluation of palliative care services. So just going a bit deeply on the first pillar, that's under advocacy. So some of the challenges which have been mentioned include limited awareness of palliative care, access to proper information on palliative care. For now, the access may be to only healthcare workers, but palliative care is an integrated service. So the information has to be tailored to all the different stakeholders who support palliative care, who support patients or people living with palliative care needs, and all the other aspects that affect someone with palliative care needs. And then inadequate information, communication materials, links with the access to information, and then limited integration of palliative care. As mentioned earlier, most people think that or relate palliative care to cancer or end of life, but it's much more, it's wider. So we are going to work on integrating palliative care to the bigger forum and other activities. And then also lack of funding for advocacy activities and training. So the priority actions include strengthening palliative care advocacy and information management to all the relevant stakeholders, developing and disseminating a communication strategy on palliative care to promote palliative care awareness and education, ensuring annual recognition and celebration of national and global palliative care events. In October, we usually celebrate the World Hospice and Palliative Care Day. However, we want to expand and even celebrate all the health days that relate to palliative care, like World Diabetes Day, World Blood Transfusion Days, and many others which people with palliative care needs whom we support celebrate. And then develop and disseminate information, IEC materials on palliative care, and promoting integration of palliative care, the information in relevant chronic disease areas and health forums. So looking at, for example, what is the role of palliative care in diabetes management? What is the role of palliative care in sickle cell management, and many other conditions and diseases that will benefit from palliative care. Under leadership and governance, some of the key challenges include a poorly defined structure for palliative care, stakeholders engagement and coordination. Yeah, there are forum and fora for engagement and coordination. However, we want to define it in a structured way, in an official and formal way. And then there's a challenge with an appropriate governance structure for palliative care, both at national and county level, and limited knowledge and support for palliative care initiative among decision makers at national and county levels, and also prohibitive laws limiting prescription and access to opioids for palliative care. Like, for example, I would say maybe nurses who have been trained especially to prescribe morphine for palliative care. Maybe they're in specialist places like hospices are not able to prescribe because of some laws which we could change and review to increase access to palliative care. Priority action under leadership and governance include establishing a well-coordinated palliative care leadership and network governance framework, mechanisms to mainstream palliative care within the health sector and beyond, because palliative care is a service that is integrated within different vertical conditions, as well as a specialized service where people with palliative care needs who need advanced care can go to. So having both models in the mainstream healthcare models, and then develop and regularly update the palliative care guidelines. Just like many other guidelines, times change and things change with a lot of evidence and research. So we need to do that. And then advocate for prioritization of palliative care resources by the policymakers. And this goes both to national level and the county level. When you are working on the budget for health and even staffing and all the rest which support palliative care. And then number 5, inclusion of palliative care in all the relevant government policies, strategies, guidelines across all the chronic diseases conditions. And then reviewing the narcotic drugs and psychotropic substances control to develop appropriate regulations which will improve access to opioids for legitimate use. Then under service delivery, there are quite a number of challenges. I'll highlight the key ones. So include the standardized package for provision of holistic palliative care services. So the challenge you have, like for example, if someone comes and asks, give me a package, I would like to start a palliative care center or a palliative care service somewhere. What do I need to do? What do I need to use? What are the standards? What are the services I need to put in place? We have them, but we need to have them in a structured, standardized in a paper where anyone can redefine, anyone can pick it and replicate in a different place. So there's poor implementation of existing palliative care guidelines. We all know that having a policy framework is good, it's very good, it's a good start. However, it needs to be implemented for it to become complete. Then there's inadequate access to palliative care services across all levels of care, and especially at home care level. There's still a challenge of provision of palliative care and recognition of palliative care at home care, and even the other different levels. There's lack of standards of care for holistic and palliative care service provision. I've mentioned part of it up there. Lack of effective public and private partnerships. As you all know, one partner is not able to support palliative care, just like many other health programs. So there's already some private-public partnership. We want to improve on that. Lack of integration of palliative care in diseases and emerging conditions, like, for example, COVID-19. Then a general lack of awareness on patient rights. I know most of the high-level hospitals have the patient charters, but if you are to ask any of the patients what it means, some of them may not even be aware of it. So that's an aspect which is a challenge on service delivery. Lack of priority of legal and spiritual needs for people living with palliative care needs. And then we have a population of aging and elders who need palliative care at one point or another. So, some of the priority actions include defining a holistic package for palliative care services, ensuring utilization of palliative care guidelines for standardization and holistic palliative care provision, establishing structures for effective collaboration with relevant stakeholders, both public, private, and mission, and even donors and other health development partners. Establishment of palliative care services in health facilities at all levels of care, that is from level 1 to level 6, as well as the community level. Number 5, integrate palliative care in all relevant chronic and emerging decisions with care models, which can be replicated and which can be used as work tools by the healthcare workers. Then advancing the inclusion of legal and spiritual support as essential components of holistic palliative care, and promoting increased access to palliative care for children. Then under the pillar for availability and access to medicines and commodities, The challenges include limited incorporation of essential palliative care medicines and commodities and equipment in relevant essential lists. And then limited funding for the procurement of essential palliative care medicines and commodities. There's also low prioritization of these medicines and commodities, and they are not affordable. So for example, let's take someone who uses a colostomy bag or who uses diapers. How many can afford to use them? Not many of them can afford. People rely on donations or many other unscrupulous means to be able to manage that. Then there's low demand and negative attitudes towards opioids. Yes, saying that maybe when you take morphine, it's you are going to die. When you take morphine, you're going to get addicted, and many other attitudes on that. You'll not be able to breathe well, and many others. And then limited capacity of professionals on use of essential palliative care medicines, and that is linked to the myths and misconceptions, which are above in number 5. Some of the strategies to address this include incorporating essential palliative care medicines in the Kenya Essential Medicines Equipment and Commodities List, enhancing funding for essential care medicine, palliative care medicines and commodities, as well as subsidizing the prices and reviewing the taxation for this medicine so that they are affordable, including palliative care in the UHC and insurance benefit packages. Yeah, this is an aspect that we've been doing a lot of advocacy on. There's still room for it, and it's really helped the patients to access, the people with palliative care needs to be able to access care when they need it without having to go through if they don't have the money and other aspects of hardships. Then improving the capacity, number, and distribution of legal opioid prescribers, in addition to doctors and pharmacists and veterinary officers, including other cadres who are well trained and able to support prescription of opioids in a well managed environment. Then strengthening the supply chain of management and reporting systems for opioids and pain medicines at all levels of care. And this can improve in reporting, it can improve in ensuring that the medicines are available at the right time and there are no stockouts. Then under human resource, there's the challenges that there in human resource and education include inadequate workforce to provide holistic palliative care services and capacity of the workforce to provide these services at the different levels of care, lack of recognition and motivation of and inadequate support for palliative care workers. There are many palliative care workers, healthcare workers who are trained and specialized in palliative care, maybe trained through universities in the, like for example, in Uganda, Oxford Brookes and the rest. However, still the system has not incorporated a way of remunerating them and motivating them with the cause. So the recognition, just the way we recognize other specialties. And then inadequate structures to promote career growth, remuneration, and recognition of basic specialist palliative care cadres. So priority actions under this include the deployment of adequate and dedicated trained workforce, building the capacity of the workforce to provide holistic palliative care services, implementing strategies to support systems which prevent burnout among palliative care providers, because palliative care providers see a range of people with palliative care needs and patients who have an array of issues, and sometimes they can get burdened because, first of all, they are few, so they see a big number of patients who also have many issues. So those strategies can help them to prevent burnout, develop structures to promote career growth and progression and recognition of healthcare workers, task shifting and task sharing for human resources in provision of palliative care services, such as in opioid prescription. And then integrating palliative care training in all curricula for health-related courses. So far, the curriculum, there's integration into the nurses curriculum, into the undergraduate, graduate, and postgraduate levels for doctors. And there are still opportunities for integrating in other cadres, for example, the clinical officers curriculum and other other cadres which provide health and support to palliative care. and then liaising with the Ministry of Education to develop curricula and roll out relevant palliative care programs at diploma, postgraduate, and even PhD levels to support development of palliative care. And then lastly, under healthcare financing, the challenges include inadequate, inconsistent collection and reporting of data on hospice and palliative care, inadequate research and building of evidence and data system management, inadequate monitoring and evaluation for palliative care services, and low use and translation of data to influence decision making. So I think this is a good opportunity for healthcare workers in this session, just to looking at the needs and the challenges and coming up with action research and other evidence building mechanisms to support this case on healthcare financing. So including review key indicators for monitoring palliative care services and incorporating them in the Kenya Health Information System, reviewing and revising the palliative care data collection tools and sensitizing the healthcare workers on their use, strengthening palliative care services and commodities management reporting, and integration into the healthcare information system, adopting digitalization of palliative care health record system, and then allocating adequate resources and building capacity for research in palliative care, both at national, at county level, and even at working with private entities and other health development partners. And finally, strengthening the use of data and research findings for policy and decision-making in palliative care. Thank you. Then, the last one on healthcare financing. The challenges include a low prioritization of palliative care, planning in both financing and national and county governments. So inadequate financial coverage for palliative care services at all levels of care, and lack of dedicated budgetary allocation to support essential package for palliative care. So the priority actions include promoting the inclusion of essential palliative care services and commodities in the annual work plans and integrated work plans, especially at county levels, because health is evolved at the county level. Although there's some discussion on that, on the development, promoting allocation of dedicated budgets to support a minimum essential package for palliative care, and strengthening the public-private partnerships, encouraging the provision of appropriate palliative care packages in both private and national health insurance funds, integrating the palliative care benefit packages within the UHC plans and budgets. Thank you.
Okay, thank you, Maculin, for that. Thank you for taking us through the various points to consider. Our next presenter is Dr. Esther Nafula from the KNH.
Maculin, please stop sharing your screen. I hope you can all hear me. So I'm going to discuss about key policy considerations. My name is Dr. Esther Nafula. I'm a palliative care specialist and the head of the pain and palliative care unit in KNH. So at this level of the policy, we are looking at actually the practical issues or dilemmas that we face while taking care of patients who need palliative care. So first, there is end-of-life care, and then there is advanced care planning, which covers advanced directives and do not resuscitate. Then we have issues of survivorship and palliative care needs for special populations. So as Dr. Zipora said, end-of-life care is not equivalent to palliative care, but it is part of it. And it's care that we give to patients when death is expected in a short time. And we need a multidisciplinary team to be able to give holistic care for the patient, their family, or caregivers, because patients need physical, spiritual, and psychosocial support from us. So the current challenges we have is that we have limited capacity of healthcare workers. We do not have any end-of-life care guidelines, so they are limited. Then legal, ethical issues and dilemmas always arise, and there's really no proper channel for addressing these issues. Then not to forget that there's a lot of cultural and spiritual aspects that come into play that might actually undermine the care that we are giving to patients in end of life. So priority actions is first to build capacity of healthcare workers, and healthcare workers here includes community health providers or the primary healthcare level, to establish and implement guidelines, to promote legislations, then to define and establish a framework on ethical issues, and also to be able to address cultural and spiritual practices. So advanced care planning, when we look at it in Kenya, there is no law yet that guides us on how to do advanced care planning or advanced directives. But generally, advanced directives are supposed to be given by the patient, not by their relatives, but by the patient themselves on the care that they wish to be given when they are incapacitated or unable to make decisions for themselves. And patients who are giving advanced directives are meant to be sound of mind or in good mental state, and they should be adults. So of course, these processes sometimes need to involve the legal team, because we need to know the implications of these forms of this process. So the legal part also comes to play. So the challenges we have is the legal and ethical challenges. For example, the practice in Kenya, you find when a patient is incapacitated, we call upon the relatives to make decisions for them, but we do not know who the patient would have wished to make those decisions on their behalf. We did not ask the patient in advance to choose a medical proxy, so we rely on whoever is available. Now, again, when there are no advanced directives, when a patient's condition suddenly deteriorates, sometimes we have to make a judgment call of whether to escalate or de-escalate care. And some ethical challenges also that come is in decision-making, especially for elderly patients who sometimes lack autonomy because their families take over because they're the ones paying the bills. Then we have reluctance of healthcare workers to initiate these discussions. And part of it is actually because healthcare workers lack knowledge on what advanced care planning is about, how to even start that discussion or when to do it. There's also a reluctance of patients to hold these discussions, because every time you bring it up that their condition may deteriorate, some patients interpret that you mean they are dying soon. So they might not really want to discuss what will happen when they are incapacitated. Again, there is low knowledge and skills on the importance of advanced directives. And there's also sociocultural norms that affect decision-making processes. In most of our cultures, decisions are made in a family kind of setup. It's a family-oriented decision even about healthcare, especially when patients are very sick and you ask them, for example, someone has kidney failure due to cervical cancer, they need dialysis. And sometimes the answer will come, I'll wait for my brother so that I can discuss with him, or I'll wait and discuss with my family. So we actually need to understand our culture and how decision-making, especially for health, is affected by those cultures and social setups. So priority actions, of course, is first to establish and then implement guidelines on advanced directives, then build capacity for healthcare workers to be able to understand what advanced care planning is all about and how to initiate these discussions with the patients, and then to empower patients and caregivers on what the advanced care planning process is about. Do not resuscitate is part of advanced care planning, and it's an order that can be part of an advanced directive, or it can be given as a separate order, but this should come after discussion with the patient when they have capacity, or when the patient is incapacitated, or maybe in ICU and is not able to communicate. That's when we get this directive from the patient's family. Sometimes the family may decide to override the DNR orders against the patient's will, and that's why this is part of the palliative care policy. So where is the legal status for this? And sometimes the patient has capacity, but then the relatives are requesting do not resuscitate. So these are some of the ethical issues that come up during the advanced care planning process that actually call for us in Kenya to have a policy and guidelines about this process. Of course, the challenges are the legal and ethical dilemmas, reluctance from medical personnel to issue DNR. And again, this is usually because of the timing. Every time we are talking about do not resuscitate, we actually have a very sick patient in the room. Then there's also inadequate information for patients to make an informed decision. How many patients in Kenya actually understand what life-sustaining therapies mean? How many of them understand what it means to go into ICU, to be on a ventilator, to get dialysis? Most of our average patients do not understand these things, so they are not actually able to make an informed decision. Then there's delay on discussions of DNR, and therefore many patients are not even able to participate in that discussion when ethically speaking, the patient has a right to make decisions about their care. But when we are going to have a DNR discussion when the patient has already collapsed, where are the rights of that patient in terms of autonomy of decision making? So of course, priority action is still the same as advanced care planning, is to establish and implement guidelines on DNR. And as I mentioned earlier, do not resuscitate can be part of advanced care planning, or it can be done independently. Then is to define and establish a framework on the ethical issues that we face every time we are dealing with patients, and to build capacity of healthcare workers to provide timely DNR support. DNR ideally should actually be done by people who are not sick, even before they become patients. They should picture the scenario of, in case I'm a patient, what kind of care would I want? Do I want to be resuscitated or not? So the timeliness of when this discussion happens should be part of the guidelines that are developed. Now, when we look at survivorship, a survivor is a patient who has been diagnosed with a serious health-related condition. So this term does not just apply to after we have treated the serious illness. It applies all through the treatment, as this patient is trying to get a balance in their life. Someone has been diagnosed with cancer today, they are going to go through treatment for 2 years. We do not wait after 2 years is when we now start saying that they are cancer survivors, or after 5 years when we've declared them cancer-free. During this journey, as they are getting their treatment and trying to achieve a balance between going to work, their roles at home, adjusting psychologically, sexually, spiritually, physically, to the illness and the treatment that is coming along with the illness. That is what survivorship means. The whole of that period, whether the patient is going to get better or not, that is survivorship. So the challenges we have is actually lack of a framework to guide the aspects of survivorship care. Most patients will tell you during their journey of a life-limiting illness that a lot of emphasis is just put on their physical well-being. Like, we want you to get better, you have breast cancer, you're going for mastectomy, then chemotherapy, radiotherapy, hormonal therapy. Nobody is giving them support on even the side effects of those hormonal therapies, as their moods are shifting from up to down 100 to 360 degrees, and they have to live within their families who are not understanding about the illness, and the focus is on, you need to eat to get better, you need to get up and go to work. So a lot of focus is actually just put on the physical aspect. So we need a framework that will guide which are the important aspects of survivorship and how can we support these patients. There's poorly coordinated multidisciplinary team approach. So it's a disconnect. The nutritionist is working by themselves, the psychologist by themselves, the clinicians by themselves. There is no coordination in the care this patient is receiving. There's limited research in Africa to guide us on implementation of survivorship programs, and there's even inadequate resources for those survivorship programs. So priority actions is actually to develop a framework that looks at a holistic approach for our survivors. Then we strengthen the existing healthcare system to ensure that the care of a patient is well coordinated. From their clinics to the next appointment, let's ensure they have an appointment to see a counselor. During their visits, we've linked them up with the social support. Not that until there's a big crisis is when we are bringing in the other team members. Then we need to promote research on survivorship and utilize evidence-based practices and allocate adequate resources for implementation of these survivorship programs. And adequate resources does not even mean that we need to pump in more money, but it means that we look on the ground, what do we have in terms of survivorship programs? What can we do at our level? Do we need to educate the people who are taking care of these patients? Do we need to set up a new program? Or how can we strengthen what is already existing? Now, when we look at this slide, there's need to ensure inclusion of everyone in palliative care, and the needs should be tailored to individual patients. So the models available that offer guidance for special groups include for care for children. It has been emphasized that our children are not receiving adequate palliative care. Yes, we do not have the data, but we have limited care for children, for older persons, for asylum seekers, homeless individuals, and even persons in long-term care facilities, patients who are being admitted in our isolation wards for 2 years. We are not giving them any kind of holistic care. Psychiatric patients who also have to stay in their wards for a long time. Our prisoners, some of them are suffering from life-threatening illnesses, life-limiting illnesses. What kind of care are we giving them? So of course, the challenges, there's no definition of palliative care packages in Kenya for this special needs population. Like for elderly people, we do not know when or how they should receive palliative care, when it should start. There is no integration of palliative care services for special populations. And of course, the biggest problem is usually the capacity. We do not have trained healthcare providers to provide palliative care services to these special groups. And the palliative care providers who are trained in Kenya, including myself, we have to give care to all populations of people, whether we know how to do it or not, we have to learn on the job. So priority actions is to allocate resources for palliative care services among special populations. We can identify who they are and what kind of services are needed, what kind of resources are needed, and just where to start. Then integrate and institutionalize identification and provision of palliative care services for special populations. And of course, we need a trained workforce to provide this holistic care or to even guide which resources are being allocated for this care. I would like to end there. Thank you so much. If you have any questions or concerns, please type in the Q&A or the chat as we move along to our last presentation. I'll stop sharing my screen now.
All right. Thank you, Dr. Esther Nafula. That was very well done. I think you have a lot of knowledge around that area, and I feel that the general message we are still saying up to this point, let's integrate palliative care earlier on in the diagnosis of the patient, so that there are so many considerations, like everything you've listed about the DNR, about the advanced directive. Those are things someone needs to do when they're before the disease deteriorates. So yes, let's really integrate palliative care. So next, you're going to have Dr. Asaf Kenyan to take us through now the implementation of this policy. What are we hoping to achieve, and who will be the stakeholders involved? Karibu, Dr. Asaf. Dr. Asaf, are you speaking? Maybe you're still muted.
Dr. Asaf, we can't hear you.
It was on water.
Okay, as we wait for Dr. Asaf to maybe handle his audio problems, I can see there's a question from Opio Dennis from Uganda, saying he holds a postgraduate diploma in palliative care with a specialization in psychosocial and spiritual care. A PG certificate in MND and BSWSA, and if he can be recruited to Kenya to teach nurses. So maybe someone can start thinking around that question. Maybe Dr. Zippy or Makiling. Yes, Dr. Asaf, you're back.
Hello.
Yes, Dr. Asaf, we can hear you now. Dr. Asaf, you can continue. Dr. Asaf.
Yeah, Lucy.
Please mute your microphones.
Lucy.
Dr. Asaf, are you able to present? Okay, let me start reading some of the questions as he sorts the issue. Someone is asking if we have a database of home-based palliative care givers and their locations in Kenya. Another one is it possible to have oral health professionals trained in palliative care? Okay. For those who want to train in palliative care and is a registered nurse, what's the way forward? Then there's another question of, can we have the ethos brought into the policies in Africa? Okay, so Dr. Asaf, are you back? Okay, Dr. Zippy, for a registered nurse who would like to train in palliative care, how would they go about it?
In Kenya?
Yes.
Yeah, well, there are two trainings that are postgraduate trainings available. One is the Kenya Medical Training College. It's 18 months. It's provided at KMTC. It's a diploma, a higher diploma in palliative care for nurses. So they usually actually advertise it when they're taking new students. So they'll be probably, maybe they're already advertised for the next intake, I'm not sure, but you can always find it from KMTC. Then there's the one for Nairobi Hospice. There's also 18 months that's given by Nairobi Hospice and Oxford Brookes University, and also they advertise usually. So you can check with Nairobi Hospice or KMTC. The other courses, of course, that take place also in Uganda for nurses. There's a prescribers course that's 8 months, I think, where nurses are extensively trained on pain management and assessment so that they can become prescribers. But of course, that applies mostly for the nurses in Uganda because we still have issues of nurses legally prescribing in this country. There's also a degree and a master's course that is multi-professional. It's not just for nurses or doctors alone, but people working in palliative care that's given in Uganda. So there are these courses that are existing, and right now there's conversation in this country there's one for clinical officers that are started in MTRH, and also the AMREF is starting one next year for nurses in oncology and palliative care though. And Kabarak University is actually working on starting a course for palliative care for nurses, doctors, and pharmacists, a degree course. So there are some things that are already happening, but there's some things that are being worked on right now. But we do have the short courses that are available in Nairobi Hospice or Nyeri Hospice, sometimes given by KEPCA, the 5-day courses, which are going to be available, I think, online soon through KEPCA as well, on an online platform training.
Hello,
Okay.
can you hear me now?
Dr. Asaf, yes.
Yes, but you need to mute one device.
You have a lot of echo.
Dr. Nafula, if you can share the slide. Apologies, I had out of office, and I think I have some challenges with my laptop. My name is Dr.
Try to,
I don't know whether Dr. Nafula, you can hear me?
Yes, we can hear you
We
now.
can hear you. We can hear you.
Apologies, had technical hitch. I think it's just when you move out of office, sometimes you have challenge with connectivity. My name is Dr. Asaf Kenyan. I'll be taking you through the stakeholders mapping and implementation matrix. Thank you, KNH team, for hosting this discussion. We truly appreciate it because this will be able to help us disseminate the information and to our colleagues, so at least we can be able to strengthen access to palliative care. So we just look at different stakeholders and their role in terms of implementation of this policy. We start with the mother institution, that is the Ministry of Health. They have the responsibility to take lead in dissemination to the relevant departments within the ministry, and it should cut across both the non-communicable and communicable departments. They take lead in developing standards and guidelines. And I'm sure Dr. Zipia has mentioned that we have a curriculum and guidelines that we developed in 2013 that requires to be reviewed. So I believe the Ministry of Health will lead us in that. And they'll also help us to develop guidelines that have been mentioned by both Maclean and Dr. Nafula that needs to be in place to streamline delivery of palliative care services. The ministry also needs to provide technical and logistical support for adequacy capacity building. They also need to provide research and support research so that we can have evidence-based practice as we continue implementing this guideline. If you look at the next stakeholder, I believe that it must be the Ministry of Education, Dr. Nafula. Yes, so the Ministry of Health and Education have a load in terms of ensuring that palliative care is integrated into the core curricula for both the undergraduate and postgraduate, mostly focusing on health-related, but should also be implemented in other courses. So at least as people, as healthcare workers graduate and they move into service delivery, they have the background knowledge on palliative care service, palliative care, and they're able to provide and support patients in need. They need also support implementation, not just having it incorporated, but it's also implementation of it. They need to also to accredit palliative care institutions or training institutions so that at least people, once they train and they graduate, also their degrees or certificates are recognized by authorized institutions. They need to also provide scholarship opportunities for training. It's quite expensive to train healthcare workers, and we need to have scholarships in place. Recently, there was an opportunity to train healthcare workers in different disciplines. And we hope as these opportunities keep on coming, then palliative care will also be factored in. They need also to ensure institutionalize palliative care in all healthcare worker trainings. And they also need to promote research so that at least we can be able to promote the quality of services we deliver. Next, the Ministry of Finance, their role is Simple, but quite crucial. They need to allocate adequate resources for implementation of this policy, cutting across the training, research, service provision, empowerment of healthcare workers, and finally, even recognition and remuneration of healthcare providers. Next. County governments, as we all know, that healthcare has been devolved, and therefore it's a role of the county government to ensure that county hospitals, and not just the level 5, but up to the level 1, that is the community health volunteers, their adequate resources are allocated to support provision of palliative care, including employment of staff who are able to provide these services. They need also to set up palliative care facilities. Currently, we have about 35 counties that have at least one palliative care unit, and we hope at least every county by the time we get to 2030, that every county will have at least one palliative facility providing palliative care services. They need to strengthen capacity building by undertaking needs assessment to identify what are the capacity needs of their healthcare workers and be able to train them. They need also to promote multi-sectorial partnership at the county level. And especially for the standalone institutions like hospices, the county governments need also to strengthen these institutions so that they can be able to support provision of services at the county level. They need to also provide policies and guidelines, and they need actually to integrate palliative care into their work plans so that at least as counties make work plans every year, palliative care should be part of it. And they need also to support provision of quality and timely reports. So at least, because again, this data will be able to help to ensure that we have timely data that can be able to help in terms of making decisions. Next. Civil societies like the KEPCA, which is the umbrella body for palliative care services, we have KENCO, we have NCDAC, and others need to have a lot to play in terms of to ensure that there is advocacy to make sure that different stakeholders are able to support this initiative. They need to participate in policy formulation so that at least policies developed have sort of a patient involvement and also has some human rights aspect to it. They need also to promote awareness on palliative care so that at least even these centers has been created, then there is utilization of the services, and they need also to provide psychosocial support for survivors and persons living with palliative care needs. Next. Palliative care providers, these are hospices, palliative care units, healthcare workers who have been trained on palliative care. They could be trained at course level, they could be trained at master's level. They need to ensure that they provide palliative care and coordinate palliative care services within your hospital. So kindly, I'll urge all the members who are attending this session that if you have been trained and your facility doesn't have palliative care services, please take that responsibility to initiate provision of these services and and also support individuals who are within your facility that are providing the care. The healthcare workers also need to influence skills and knowledge through on-job training, mentorship, and research. They need also to help to strengthen the referral system at all levels of care, and they need also to support implementation of palliative care services at all levels of support so that there is continuity of care up from the community level up to level 6 or tertiary levels. Regulatory bodies, these are the likes of the Pharmacy and Poisons Board, the Medical Practitioner Dentist Council, the Nursing Council, the Clinical Officers Council. I know even the Physiotherapy Council has been greatly involved in this. So they have laws, one in terms of accrediting palliative care sites. They need also to provide some sort of leadership and organogram so that people who have been trained then can have sort of leadership load in strengthening the provision of the services and implementation of this policy. They need to also to regulate and enforce so that at least we ensure that people who have been given the responsibility to provide these services, they practice within their scope. And those who are practicing without outside their scope, then they need to sort of be supported to ensure that they adhere to the guidelines. They need also to advocate provision of guidelines on palliative care matters, and they need to provide a direction on prescription and handling of opioids for palliative care. As Dr. Nafula mentioned, and I think also Dr. Zipi, is that very few healthcare workers have been allowed to prescribe opioids, and that also becomes a barrier because if, let's say a hospice has only nurses and nurses are not allowed to prescribe opioids, so what happens to a patient in that facility who requires support? So there is need even to sort of have a direction and discussion in terms of allowing other prescribers and to be able to prescribe and handle opioids. Next. KEMSA, we all know that they have a role in terms of ensuring there is adequate supplies of medicines and non-medical supplies to our facilities. So they need also to ensure that apart from that, also that we have a regular supply of oral morphine. Over the last 2 or so years, we have been having lapses where we have stockouts, and the KEMSA need to ensure that we have adequate supply of morphine and other requirement, non-medical supplies, including colostomy bags, and also not just ensure there is supply, but also to ensure that there is also the quality is also adhered to. They need also to facilitate procurement, storage, and distribution of essential palliative care commodities. They need to invite other stakeholders to support the procurement, and they need also to identify and recommend digital technologies applicable for the sake of supply and distribution of palliative care commodities. Next. Training institutions, they need to institutionalize palliative care in all healthcare training programs. They need also to promote establishment of palliative care education and training programs. They need to help in terms of conduct palliative care research. And also they also need to help in terms of dissemination of those research findings, be it publications, be it even creating forums where people can be able to share their experiences and knowledge. They need also to inform and guide policy review and development of palliative care guidelines. And they need also to support community awareness creation on palliative care. Next. NHIF and other medical insurances. As you are aware that there have been several reforms towards strengthening NHIF package, and we need to ensure that these insurances, including the private insurances, provide timely and comprehensive medical insurance package for palliative care. Not just survivors, but even the patients who actively receiving palliative care, they need to be well supported through these insurances. Next. The public and persons living with palliative care needs also have a role in terms of implementation of this policy. They need first to utilize the established services. As you're aware, we have about 15% of adults accessing palliative care services and about probably less than 5% of pediatrics accessing palliative care services. So these individuals need to start utilizing services so that at least they can be able to have quality of life. They need also to participate in policy formulation, implementation, and improvement. And there's a slogan that nothing for us without us. And therefore they need to be heavily engaged to ensure that they participate in policy formulation. And even when we are developing this policy, persons with palliative care needs were heavily engaged to ensure that their needs are factored in. They need also to participate in awareness creation and communication within their communities. Next. Legal practitioners, as Dr. Nafula mentioned, we have a lot of legal issues, and especially towards the end of life. And therefore, legal practitioners have a role to play in terms of providing legal guidance to healthcare workers, policies, and persons living with palliative care needs on palliative care. Next. Development partners have a role to provide technical and financial resources for implementation of this policy. And they have been very supportive in the past, and we hope they will continue supporting government and civil societies to ensure that this policy is implemented. Next. Media houses. Media has a big role to play. We always say that they are our mouthpiece because they're able to influence narrative within the country, and therefore media houses need to create awareness on palliative care. They need to advocate for quality reporting on palliative care, and they need also to help in dissemination of accurate palliative care information to create awareness and also to try and demystify the existing myths within the community. Next. I saw a comment on somebody asking whether there's a role for complementary and alternative services in palliative care. And one of the things this policy addresses is that we need also to consider engagement with herbalists, traditional healers, spiritual leaders, so that to ensure there is cohesion and well-coordinated care to patients. And therefore that will also help in terms of improving quality of life and avoiding sort of competition that end up hurting the patient and the family. Next. Definitely we'll have to ensure that we monitor and evaluate this implementation of this policy So we'll have annual plans, and I hope the Ministry of Health will be calling us every end of year to look at how are we feeling in terms of implementing this policy. Remember, this policy expires at 2030, together with the Vision 2030 of the country. So we'll monitor it annually. We'll also have a midterm evaluation and end of term review. There will also be revisions as things keep on changing. Most of us, we didn't anticipate that we'll have COVID. Now COVID is in place. We don't know what else Chinese are going to eat or interact with that might influence our healthcare, and that might also you so keep on looking at the emerging issues and factoring them in the coming years. So we have some few key indicators for this policy. One is the patient access in palliative care. Currently, we have about 14,000 patients accessing palliative care. We hope by the end of 2030, we'll have about 400,000 accessing care. We will have, currently we have 5 counties that have included palliative care in their strategic plan. We hope that by the end of this policy, that is in 2030, we'll have 47, all the counties having a strategic plan. We'll also we hope that we'll have a good allocation of palliative care in the budgets, both for the national and county, and very reflective. Currently, there is no very clear data on showing how much is going towards palliative care, but we hope we'll be able to document that. We hope that we'll have palliative care personnel dedicated to provide palliative care. By the 2030, we'll have 5,000. And we hope that we'll also have nurses who have been trained to handle opioids, that we'll be able to move that number from 100 to 1,000, and also have 14 core curricula that have integrated palliative care. And this, I believe, will be able to push and help in the implementation of this policy. Next. Dr. Nafula. So some of the key messages is that palliative care approach can be offered by any cadre of healthcare worker, community health care, and community health volunteers at all levels of care. So we don't have to keep on referring patients to higher facilities. We need to look at our facilities and see what can we offer to these patients at our level. We need to ensure that palliative care is included in pre-service and in-service training. We need to ensure that facilities every county has at least a facility providing palliative care services. We need to ensure that there is budgetary allocation for palliative care. We need to ensure that NHIF covers palliative care, and there is also legal awareness to those in need, and it really to create also a lot of awareness on palliative care services. Next. I want to stop there and invite questions. I think we will now move to the Q&A section where we'll be able to respond to issues raised. Thank you very much.
Thank you, Dr. Asaf, for taking us through the implementation of the policy. I hope everyone present has seen where they fit in the implementation. So let's try to do something about it, so that by the end of the 2030, we'll actually see the progress made. All right, so I'll just go through some of the questions that have not been addressed. I think this one I can address to Dr. Nafula. There's someone asking about if a patient is not 18 years and over and the family is not there or not able to make a timely decision, and then now we have to involve the legal team. How fast is this legal team able to come in so that we don't risk delays? And also, whose cost is it for involving the lawyer? Dr. Nafula, I believe you may have come across such cases at KNH.
Now you say such issues are dealt with at an individual institutions. It depends on what you do at your institution. For example, in KNH, we have an ethical committee and we have a patient affairs department. So such issues are handled through that channel. So I think the biggest assignment is to check within your institution what kind of support exists. Is there an ethical committee? Do you have an in-house legal team? Because that's where such issues are addressed. But I think where there's non-existence of such teams is why we are advocating for having a policy on these ethical and legal issues that arise in care, because someone less than 18 years is actually considered a child. Therefore, someone has to take responsibility of the decisions being made. But the best way is to deal with it on an individual basis within the institution.
Okay, thank you. Thank you, Dr. Nafula. I think what I'm hearing from your end is that the different facilities can leverage on this policy to advocate for a legal team to be put in place, an ethical team, a patient support group, just if someone is asking you why you're advocating for such things, just refer them to this policy. And if you've not mentioned it, the policy is available on the MOH website. So you just go to MOH, you can Google it, and then just go to the downloads. You will find it there as the National Palliative Care Policy. There's someone asking about fellowship program in palliative care. Dr. Asaf, is there an opportunity for someone to do a fellowship under the IAHPC fellowship program?
I think there is an opportunity, but probably Zippy could give more information. Zippy?
Dr. Zippy has logged out. She says she has another meeting where she's a panelist. Now, I think the challenge we are having, and that's why Dr. Asaf was saying that the Ministry of Education is also a key stakeholder, is that palliative care education is not locally available. Like the fellowships, yes, they're there, but the IAHPC fellowship you'll find is in America. So the fellowships exist, but not locally. In fact, the nearest we have to any good programs is in Makerere. And now Moi University is starting a higher national diploma, but for clinical officers.
Okay, and someone else is asking, is it possible to have oral health professionals trained in palliative care?
Yes, we actually have a few.
Okay. And they can get that training at KMTC or at Nairobi Hospice also have. Okay. There's another one who asked, can we have the ethos brought into the policies in Africa? Dr. Nafula, are you able to address that?
I think it's possible. For now, you see, this is our initial policy. It's our first policy. So of course, with time as we implement, we'll see what needs to be added on by the time we are doing a review of the policy. So those key indicators and the monitoring that we need to do annually will actually reveal for us maybe what further needs to be added on to this policy. Dr. Asaf, do you have any comment on that?
No, I think what you have responded is quite correct. But I think what also did, we borrowed heavily from our colleagues in Uganda and other places when we were developing this policy, and some key aspects raised have been addressed by the policy.
Okay. I'm seeing someone is recommending that we should take this up to the parliament level so that you can get financing and legal support. And I concur. This is just the start of the dissemination. So we shall definitely push this policy document to reach all the relevant persons. I can't see any other question. I'm seeing a comment someone is saying the information was well presented. And they're asking, is palliative sedation practiced in Kenya? Dr. Nafula, we have such a thing?
Yes, we have palliative sedation, but remember one thing that we've highlighted even in the policy is about our culture, because typically palliative sedation is done in the last 3 days of life when someone is going through the active phase of dying and they're having a lot of restlessness, a lot of pain sometimes. And sometimes if you give the medication for palliative sedation, the patient actually becomes sedated. And this is a patient who is never going to wake up. So the relatives might actually say it is your medication that killed the patient faster. So we actually do it very cautiously. And part of the recommendations that we are using now is you decide whether you are managing pain or agitation. So for example, if you're managing pain, you tend to use opioids like morphine. And if it's the agitation, then you might want to use benzodiazepines at low doses. But you have to explain to the family the medication you're going to give and why you're giving. And they need to understand at what phase of the illness you've gotten. Otherwise, they'll say it's the drip that was put up that killed the patient, and then the myth that morphine hastens death will keep circulating in the community.
All right, thank you for that. There's a question on home-based palliative services. Someone is asking if we have a database of the home-based palliative caregivers and their locations in Kenya. Maybe Dr. Asaf, you may have something on that.
Yes, the Ministry of Health has first developed a tool and allowed all the palliative care providers in the country to liaise with KEPCA to get that tool so that they are should be able to report data on the patients they are seeing and the conditions and the challenges they are facing. That way we'll be able to generate more data that will be able to help in our advocacy and resource mobilization. But also KEPCA has also been collecting the data on service providers. So if again you go to their website, you'll be able to find different service providers with different classifications and where they are based. So that information is available.
Okay, thank you.
I'd like to add.
Yeah.
I'd like to add on home-based care, palliative care. Just to mention that there's an opportunity of integrating palliative care in home-based care. Because first of all, we have the policy, the community health policy and the strategy, which highlight some of the roles of community health volunteers, and some of them are roles which support palliative care, such as screening and supporting people with palliative care needs, those who are not able or are not able to be at the facility. So it's also it's a good opportunity which as palliative care providers and stakeholders, and with the support of the policy, we are looking into embracing it and even coming up with structured pathways for home-based care as a model. Thank you.
Okay, thank you. I believe the home-based care really comes in handy, and I believe even one of the objectives of this policy is that we reduce the cases of hospitalization by managing some of these conditions at home. So I believe that's a major area. Okay, I don't know if there's anyone we've left out. So the link for more information on KEPCA, you can just Google KEPCA, KEHPCA, and you're going to see their website and find more information on that. And on the downloads on the MOH website, you can find this palliative care policy. You can use it to refer. I think we shall share the slides. KNH research, is that possible? We can share the slides with the participants after this, just so that they can use it for their reference. Okay, I'm seeing some more comments are coming through. When a patient is on a terminal stage, the DNR policy may have a negative impact. May have a negative impact on the caregiver, hence doesn't show keen interest checking on the patient. Oh, okay, what's your take on this? All right, let me read again. So when a patient is on the terminal stage, the DNR policy may have a negative impact on the caregiver, hence doesn't show keen interest checking on the patient. What is your take on this? Dr. Nafula?
Yes.
Have you understood it?
Yes, I have. Now, remember we said the timing of discussing DNR is very important. So we do not advocate for DNR to be discussed when a patient is in the terminal phase of life, because of the reason you've actually given, that it has a negative impact on the caregiver. So DNR discussions are ideally supposed to be done early. So if people do not understand what DNR is, for example, in Kenya, that's where we are, the best timing to have a DNR discussion is at the time of diagnosis. When someone has been diagnosed with a disease that is likely to get to the terminal phase, those are discussions that should start early for the patients and families to start discussing among themselves that supposing things got worse, actually what kind of care do we want? Do we want this person in ICU? Or do we want to give them the best supportive care? Do we want them in hospital or at home? So the best time is before the patient deteriorates and before they get into that terminal phase. And those are some of the things that will actually be highlighted if we have an advanced care planning policy, which will also include that portion of DNR.
Okay, thank you. Thank you, Dr. Nafula. Another person is asking what percentage of the population see a health worker? Okay, is it like the palliative care worker? Okay, from our figures, we said maybe around 15% access to palliative care services in 2019. I hope that answers that question. There's someone with a concern on monitoring and evaluation, whereby I'm concerned that this is a program ending by 2030. Now that it has been of great importance to the public, I feel it should be part of government to stay. Now that cancer is a long-term condition. So on that, I will answer that. When we say it's from 2021 to 2030, it doesn't mean we're going to end it there. It just means that we want to gauge the policy from this time up to 2030. We implement it. By the end of 2030, we'll bring like another version, which will be informed by what will be happening in the country at that time, and the progress we'll have made, and we shall see what adjustments we need to make. So it doesn't mean we are not going to continue with the policy. Another question is, in some points, there's low supply of morphine in the government hospital, and you see patients moving from one community to an community pharmacy to another looking for it. What's your plan on the same? I know several outpatients having sleeplessness looking for it. I can answer that, but maybe I direct it to someone.
No, it's okay for you to answer, Doc.
Okay. All right. So we actually have a morphine plant, like a morphine facility at the KNH, where we reconstitute morphine and we supply it to all the hospices and all the government facilities in the country. So if maybe people are not aware, they should actually reach out to KNH. You can reach out through the KEPCA team. They will connect you to the KNH team, and this is free of charge. So, and we really try to like up the supply so that we're able to satisfy the need that is there in the country. And sometimes we may have a delay, but we really try to supply the morphine to all the facilities. So in case any facility is lacking, please just reach out to the KEPCA team. They will assist. Okay.
Just to add on what you've said, Joy Frida, if you allow me.
Yes, David, yeah.
So we currently coordinating the distribution of morphine, and it will be good if that person, it's taken or somebody, if they could identify themselves and let us know which facility that is. But we're working closely with KEMSA so that the supply is just like the way government supplies any other institution in Kenya. So I hope they will be able to identify themselves and reach out to us. Thank you.
Okay, thank you, David, for that. Okay. I'm seeing there's someone asking for Nairobi Hospice to to host them for the fellowship. I think I would recommend you get in touch with Dr. Asaf. Just go to the Nairobi Hospice platform. There's a contact number there. They can assist you further. Okay, any other question that I have not addressed? Okay, I hope there's no question I've not addressed. Okay. So any last remarks from our panelists? Maculin, maybe you can begin, then we go to Dr. Esther and then Asaf.
Thank you so much, Dr. Frida and the participants, the panelists for the session. I just want to mention that this having the palliative care policy is a good opportunity. It's a good opportunity for all of us. However, for the implementation of the policy, we need all the stakeholders to come together, to be dedicated so that we can combine efforts, resources to be able to implement the policy. Because the policy without implementation becomes just a document like a newspaper and all that. So we're excited that you've been able to join, and we believe that with your support, you can work together and support the implementation. Thank you.
Mine is to say thank you for sparing time this afternoon to come and listen to us talk about our palliative care policy. And we hope that all those who are listening will help us as we strive to implement this policy and actually make palliative care accessible to the patients and families who actually need it in Kenya. Have a lovely afternoon. Dr. Asaf?
Yes, we say palliative care for all, and it's everyone's business. So my hope and plea to all of us is that we're going to advocate and push our government, our policymakers to allocate adequate resources. And we're also going to devote our efforts to ensure that people with palliative care needs are well supported. Thank you all. Bye.
Okay, thank you everyone for attending. For Opio Dennis, we've answered your question on the chat, but you can still contact KEPCA team. They will assist you further. KNH team, do you have any announcements to make on the CPDs? I've seen some people inquiring on the CPDs. Okay, the CPDs should be sent to your emails. The timeline is around 2 weeks from now. So just look forward to that. In case of anything, just go to your email. When you registered, there was a confirmation email that was sent to you. And there's a contact address there in case your CPD points are not given. So I'd like to take this opportunity to thank each of you. We've actually reached a very good number in this first dissemination webinar. So we thank you for your participation. Thank you for attending this webinar. As the Ministry of Health, we are keen on addressing various issues surrounding cancer management in the country. So we actually advocate for a holistic approach. We advocate for proper screening at all our facilities, from the primary health care, from the ground facilities. We advocate for screening. We advocate for diagnosis. We advocate for treatment. We are setting up a couple of regional cancer facilities where you can get treatment. Actually, you can get chemotherapy, you can get surgical services, and even radiotherapy. We are about to launch radiotherapy facilities in Nakuru, in Garissa, and in Mombasa. So look out for that. And yes, even in terms of survivorship, in palliative care, we really want the cancer treatment to just be wholesome. We want it to be holistic. We want everyone to be involved. So thank you so much. Let's all be ambassadors of palliative care moving forward. I think that will be the biggest impact of this webinar. So thank you very much, and Have a good afternoon. We look forward to having more engagements in the future. Thank you.
Thank you.